Well, welcome to GLAD. I'll hold off what GLAD is, unless you all know, until a few slides into it. Just want to quickly acknowledge where GLAD came from. So it's actually a Danish study, originated in Denmark and then got brought to Australia through the help of GLAD Canada. And then with La Trobe University in Melbourne, they've brought the whole GLAD Australia program out for us. So what does GLAD stand for? It stands for Good Living with Osteoarthritis, and the Denmark is where it came from. What the program essentially contains is 2 education sessions, one of them being tonight, which is a bonus, and then 2 exercise sessions a week for 6 weeks, so 12 exercise sessions in total. That is the minimum dosage for what's recommended for this program, and the results from the program are based on that. Some of you may end up doing it 3 times a week, some of you may be doing it more than 6 weeks. It's up to you, but that's the minimum recommendations. A good point to note though is that although that's the minimum recommendations, exercise and lifestyle habits is hopefully a lifelong kind of thing that we adapt to and change, not just for osteoarthritis, but for all the other health benefits that being physically active contains. So some of you may start the GLAD program and continue within whatever journey, whether it's us, at home, in another gym, but that's one of the hopes with this program as well, outside of all the benefits that it has. Hopefully after today, the idea is that we'll get a better understanding of what osteoarthritis is in general for ourselves and how we may all differ. Go through the range of factors that influence pain and disability. So osteoarthritis involves the joint, but what else does it contain and what else influences those, and how can we then target and improve on those factors? And also just the treatment options that are available, what's recommended, and even things for self-management. And overall, the idea for GLAD and just, I think, exercise physiology in general is all about empowering your lives so you live better. That's all we want at the end of the day. It's a simple but hopefully effective message. So how common is osteoarthritis? It's actually the most common lifestyle disease in those over 65 years old. Maybe a surprise, especially against things like blood pressure and diabetes. I was quite surprised. It's quite a good fact. Also can be seen in those as young as 30, especially those who come from contact sports backgrounds like AFL. We see a high prevalence of osteoarthritis, so it's not just a disease that you see in the older generation, it's across the whole lifespan. In Australia, there's about 2 million people with hip and knee osteoarthritis, let alone the rest of osteoarthritis. And with the aging population, we expect this number to increase. Equates to about 1.5 million of those seeing a GP. Huge numbers, but what I find really kind of interesting is that there's about 500,000 difference between those who have osteoarthritis and those who are potentially seeking treatment or not being available to seek or access treatment. So there's a huge number that may be missing out. And hopefully just through this program and exercise, we may be able to bump up that number for those getting help. So the big question is, what is osteoarthritis? We'll raise hands and discuss that, but really it's a whole joint disease. I think quite commonly it's thought of being a bone-on-bone disease, issues with the bone or with the cartilage, and that's it. But more so, it's actually the whole joint that surrounds the hip or the knee. You may or may not have heard the wear and tear kind of coin for osteoarthritis. The reason why we try to move away from this is that with wear and tear, we kind of start to think that activity should be avoided, rest is important, doing less may be better because we don't want to induce more wear or tear. What the evidence shows though from research is that we actually need appropriate loading to kind of nourish the joint, especially the cartilage that provides shock absorption and keeps our bones healthier for other parts. That's really key. So if we try and move away from the wear and tear and focus more on what we can do for the knees and with a bit of activity, that's kind of the goal for improving osteoarthritis. Another thing is scans can be frequently overemphasized, depends on the person and depends what scan you get. But if we're just looking at osteoarthritis in general, scans such as x-rays don't actually tell us too much. They may show that there's some structural change, but that doesn't necessarily result in the function, the pain, and the symptoms that we experience. Interestingly, some people may have osteoarthritic pain and symptoms for 10 to 15 years before it shows up on X-ray. Some people may have X-ray showing quite severe structural degradation and have little to no symptoms. So it starts to raise a picture that there's more than just the scans, more than just the structural part. There's a whole other areas that we kind of explore and hopefully improve through physical activity is one answer. Other answers that I'll discuss as well today.
Does an MRI show up your osteoarthritis?
MRI is good for detecting cartilage, so the parts that surround the end of the bone. Something that the X-ray doesn't show up as well. It can also show more so inside the bone itself. Potentially if there's any other issues that may be related to pains, potentially might not be osteoarthritic, it could be another reason that you may be experiencing pain in that joint. And so it's a great question. If you think that something maybe else causing the pain outside of that, then scans, especially MRI, are really important to definitely figure out which is the resulting factor. So I sort of talked about the scans, and that's sort of where we start with osteoarthritis. We may or may not get a scan, and it may or may not show osteoarthritic kind of signs. But what else can we target? Or what else maybe influences our pain and disability? Things like being overweight potentially, muscle weakness, especially in the quadriceps or the front of the thigh. There's a strong correlation between weakness in the front of the thigh and developing or having osteoarthritis. Doing too much. So we talk about physical activity, but in the right dosage, the right amount. It's not going out there and running a marathon, or unfortunately getting tackled in soccer and that causing the pain. Is find the right level for you. Fatigue and even being inactive is also a risk. Poor sleep, social stress factors. Stress has a large influence on pain. That's something that we can, it's not as easy to target just through exercise, but hopefully through improving confidence, being around people who are doing similar things to you, having those discussions can have an effect on that side of things. And then there's the part where we talk about our beliefs around pain. What are they? How strong are they? Can we discuss them? And then also, how do we manage them? And those type of things that come from more the brain and the mental aspect, which then link to our pain. And although we're exercise physiologists, exercise is just a component of what we offer. We then also offer the sort of the mental aspect for talking and discussion, figuring out what's affecting you, why, the larger picture that we can kind of hopefully try and improve to some aspect rather than just the physical side of things. And I hope I sort of mentioned that, just going back to this, we may have the structural side, but each of these things can be targeted through the GLA D program and beyond. Some things we can't change, but it's still important to be aware of our age. We're yet to find the magic potion that prevents us from aging, but hopefully one day. 6, so women are more likely to get osteoarthritis, especially in the knees and hands. Men are more likely to get osteoarthritis in the hips, and then also younger men are more likely to get osteoarthritis just from the history of playing contact sports. Interestingly, with AFLW, it'll be interesting to follow the research from their side of things. Something just to bear in mind. And then if you have a family history of osteoarthritis, you are more likely of developing it as well. But if you can, I guess, incorporate some physical activity, no matter what the level, it can have some improvement towards all these. I've started to sort of paint a picture that X-rays maybe not be the best idea for osteoarthritis. Another kind of much more affordable and quicker way can be having a clinical diagnosis. And that's based off your risk factors, your clinical examination that you'd have with your clinician, and also the pain and symptoms that you present. You present some of these, and it's likely that you have some level of osteoarthritis. The severity, you can't tell until you have an X-ray, but the severity doesn't always link again to the pain. So you could have mild severity on the scans, lots of pain, high severity on the scans, not much pain. So the correlation is quite poor. I want to talk more about the actual joint itself now and the factors that get influenced when we have osteoarthritis and parts of the joint that get mostly impacted, one of them being the articular cartilage. So it's a smooth surface that surrounds all our bones and our joints, acts as the main shock absorber for us. And so if that's starting to degrade, then we're no longer absorbing those shocks as well. That starts to put more stress and pressure onto our bones, and that causes damage, and that's when we can potentially start to feel these symptoms. Interestingly, with articular cartilage, there's no nerves or blood supply. So there's no nerves, so the degradation of cartilage doesn't result in any pain itself. And there's no blood supply, so it's not being nourished by blood like all the rest of our organs and systems do. Instead, it gets nourished by what we call synovial fluid, which is inside the joint capsule. So each joint is surrounded in a capsule, and that is filled with synovial fluid. The way that we actually nourish cartilage is through movement and appropriate load.
Sorry, how do you spell that? Synodal fluid?
Synovial fluid, good question. I wonder if it's on my next slide, but otherwise I'll spell it. There we go. SYNOVIAL.
Thank you.
I'll move to the slide. I'll still talk about the same point. But we require adequate loading and deloading of the joint to nourish our cartilage. When we put pressure on a joint, it secretes synovial fluid around the cartilage, and then once we reduce the load, that cartilage acts as a sponge and sucks it back up, and that's where it gets its nourishment. So I kind of think about it in the same terms of eating. If I'm not eating and fueling my body is not going to grow, it's not going to kind of be happy. So if I'm not loading my joints properly, it's not going to be having the same idea. Same if I was to eat far too much, the same idea that if I loaded the joint far too much, it would also have negative consequences. So it's all about finding the right balance. With the knee joint itself, it's easy to think about osteoarthritis is, again, just a bone and cartilage idea. If we draw the bigger picture where we start to think about things like the menisci, which add as another shock absorber, the muscles and ligaments, which provide support to the joint and also move the joint for us. It's a whole bigger picture now that we can target different areas through our prescription to improve pain symptoms. And just down the bottom, it's noted that it's not always clear which exact structure or system is the one causing the pain. It could be muscle weakness, it could be tendon damage, it could be cartilage degeneration, it could be a combination of all factors. And so fortunately with exercise, we can essentially target each factor in one group. Just comparing the knee and the hip joint, the only difference, well, lots of differences, but in a nutshell, the knee is a bone-on-bone joint. The hip is a ball and socket joint, which adds some more stability to it. It doesn't have any menisci, so it lacks that additional shock absorbers that you would have with a knee. But it still has the same principles. It still has the muscles and ligaments surrounding it for stability. It still gets nourished by the synovial fluid that gets it from the load.
Sorry, can you go back
Certainly,
to that one?
yeah.
Sorry. Thanks.
So if someone has an accident with a hip bone and that synovial fluid disappears to a certain extent, can it be replaced?
So it's going to go down from initial injury, and that itself then I guess means there's less nourishment for that cartilage for a given point. But if we can, through many other factors outside of exercise or just the natural healing process, I can get into all the science later on if you like, but that does, outside of exercise, come back to kind of normal, or should return to normal levels.
I'm just very curious. I have a girlfriend who was operated on 2 years ago.
Right.
She's 10 years younger than me. The hip's gone out 5 times since. And the specialists have done all sorts of things, including the latest, more or less making a cartoon, watching her walk at the hospital and taking all these different pictures to see
how
what stresses on the hip.
And that raises a kind of an interesting point, is that hip itself, once it is injured, same with most joints, they can then become more lax, so they've lost that build stability, whether through damage to the tendons that provide, also like the ligaments that provide the support, if they become torn or laxed. And so not in a clear or easy picture for your friend, but the idea is if then we can strengthen the joint, so the muscles and tendons get stronger around that, that can sort of replace or kind of support support that lost stability that was initially there, not to the same extent, but better than if it was left on the way side of that. Makes sense.
Yeah, the initial operation was perfect
Mm.
and perfect alignment, and then she slipped doing weeding on the embankment. It's gone in and out ever since.
Yeah, yeah, that's really unfortunate.
So I thought it may be that fluid, or it may be tearing from outside because the bone structure seems to be in place.
Yeah, sounds more like the tearing, but probably all has a impact. Each part all has its own role.
Thank you.
Yeah, not at all.
So when the tendons get, you end up with tendinitis in a number of the tendons.
Yep.
In the hip. And a torn, what's the name of the one that goes down from your
hamstring.
buttock, your hamstring.
Uh-huh.
Yes. That's all to do with what, wear and tear, or it's because the arthritis in the hip, or what?
Yeah, that's also multiple factors. The tendinitis, or sorry, tendinopathy, where it's like an inflamed tendon.
Yeah.
Many factors. One can be an arthritic hip or knee.
Yep.
Where the hip no longer moves as well as it should.
Yep.
That pushes additional stress on certain tendons that are depending on where they most find it. The muscle itself being torn, that's a wear and tear to something, or like a potentially an acute injury where something significant has happened all at once, and the load was too much for that muscle to sustain. Or if there's initial muscle weakness through just many factors that relate to not being able to be physically active, that's already weaker, and then say when an external force comes on, it's got less chance of kind of resisting that force, and then it tears.
So the hamstring tear, which is 50%, does that repair itself?
It can, yep.
It can?
Yep.
50%?
Yeah, at that extent you're looking probably more potentially at a surgery option, but otherwise they can still do a lot with a torn hamstring. It's not going to have the same function as it was perfectly, but even through rehab you can still get back to what we consider normal range. That allows for normal function, but it's just being mindful of everything that comes with those limitations.
So when I'm being told that I've got all of these things, plus I've got osteoarthritis in the hip, which came first, the osteoarthritis or the
That's the chicken and the egg story. Yeah, exactly. It's a good question. I could put a guess on both. I'd have to discuss with you more to potentially get a more clear example, but yeah, one could cause the other in a sense.
Yeah.
Yeah.
There was no actual accident.
Yeah. Any other questions for now? I've talked about this briefly, but let's go into a bit more detail. So with the picture on the left, looking at the top arrow, where the top arrow represents degeneration of the cartilage. And this occurs through inappropriate loads, lifting something far too heavy than we should lift, or doing something repetitively that's not very safe from a joint perspective, such as moving your house multiple times, lifting heavy boxes, things that are awkward and puts more stress on your system or your body than need be. Or we're too inactive, so we're not getting enough stimulus to actually regenerate. So on this one, there's too much load, too much generation. The arrow is too small as they're not getting enough of that balance, and that's where it gets the loss of cartilage. On the right hand side, this lovely person is doing the optimal load, and optimal load is independent for everyone. So something that Brenda does will be something different to what Leslie does in the program potentially. But it's finding what's right for you. So everyone will have their own level, but if we can get to what's right, then likely we can maintain your cartilage and even try and replenish and restore the volumes of that. Some signs of osteoarthritis, and if you're here tonight, it has a guess that you may already have some osteoarthritis, but potential kind of other things that you may or may not be aware of. Pain with weight bearing is a common one, and that morning stiffness, that kind of wake up and you feel stiffer or tighter or sorer. and it hopefully improves as you become more move around throughout the day. But as your osteoarthritis kind of persists and becomes like a more long-term lifestyle disease, you may experience that pain again at rest, at nighttime, or throughout, with or without activity, which is really frustrating. And so hopefully we can kind of trigger that and improve that.
Yes, okay. Can I ask a question?
Certainly.
I wake up with a lot of pain in the legs in the morning, but after I'm walking okay. But it's not nice in bed. And is there anything you can do? One second. Is it maybe the way I'm lying, or?
Yeah, I wouldn't say so much the way it's lying.
Lying.
Yeah,
Yes,
lying.
Yeah, I'm lying in bed.
Yeah, lying, but yeah, I get what you mean. Yeah. A cheeky thing I say is you can do the GLAD program would potentially resolve the issues.
Right.
But from a longer answer, I don't think it's so much the line that's causing the pain. It's just if it's with osteoarthritis, we may be avoiding or doing less activity than we would like to do potentially.
Yeah.
And so going back to what's needed for a strong and healthy joint is appropriate load. And so if we're not getting that load, then potentially no matter how we sleep, we're still going to have that underlying factor. The fact that you wake up and you move around and it starts to feel better is sort of evidence for exercise, and it explains the way that osteoarthritis works. Is once we kind of get the joint moving, we're nourishing it with that synovial fluid, the blood's flowing around the joint. Those factors can ease the pain. So I say in the short term, it's just being mindful. Massage and gentle movement in bed may help before you get up. Massage before you go to bed may help. Ensuring that you're warm enough in bed, especially in winter time, may help in the morning. But those are just short-term factors. And I think potentially get the long-term improvements, that's where I guess this program comes in.
Someone suggested putting a pillow between my knees. Is that a good idea or not?
You can try it.
Right.
Yeah, people do that for lots of hip injuries.
Yeah.
But same being, you're welcome to try it. Yeah. Again, just common things you may experience with osteoarthritis, and one that we all kind of hear about is trouble putting on socks and shoes. Things that we do in day-to-day life, and that's where it really becomes important when you have your initial assessment or your subsequent appointment with your exercise physiologist, is that you discuss what's important to you, what sort of daily activities you're having more trouble with. So it's not just an exercise program to improve your pain, it's also an exercise program to target what's important to you to allow you to function better in day-to-day activity. So these being the common ones, but you may have your own personal ones. And if we're aware, then we can actually modify and adjust your exercise prescription to achieve these goals that you may have. Fatigue is another common experience with osteoarthritis, other chronic diseases. You may have underlying fatigue, and fatigue is something you can't just sleep away. It's a chronic illness. And say if we're being less active because of our osteoarthritis, then our muscles and our aerobic can reduce, and then we do a day-to-day task, and that's naturally harder because we're a little bit weaker and a little bit less fit. So we have to exert ourselves more. That increases the fatigue, and it's almost this negative cycle, which is horrible to think about, but it's the way that can add to it. So if we can again improve in some way to allow ourselves to be a bit more active, it takes the burden off our day-to-day tasks, may reduce that fatigue, and may make us feel better overall. Here is sort of the idea that I'd like you try to potentially all ingrain in your mind of what's the approach to osteoarthritis. And I'll go all through these separately. The key one is anyone with osteoarthritis or joint pain should have education, exercise, and potentially weight control if needed as their first step. If that isn't working or needs help to work, we look at the second line, which is where we start to add in pain medication, your Panadols, your Nurophens. I'll talk more a lot to that, but just the idea, changing your footwear and so on. And then some will require some level or joint replacement surgery, and I'll discuss all of that in due time. With the first line treatment, this being education, exercise, and weight management, it's important to understand that exercise is effective for pain relief. And there's different types of exercise you can do. I'm just going to put Claire and Brent on the spot. They come to one of our group classes outside of this and a bit, and they do aerobic exercise such as cycling. They'll do some balance training. They'll do what we call general strength exercises, and they're all benefit for a range of health reasons, also osteoarthritis. What this program tries to focus more on is the neuromuscular control of exercise. And what does that fancy word mean? It really just means moving your body in such a way that you're not overstressing the joint, and that you can move. You're doing exercises that are functional and replicative of what you do in day-to-day life, such as walking upstairs, bending over in the garden, getting in and out of bed, up and off the floor, if that's something that you need to address and work on. So it's more functional, and it's more kind of doing exercise with that correct control, load, and movement. And that's sort of what separates a GLA D exercise program versus just a generalized exercise program. But they all have benefit. And like I said at the start, you may do this to improve your pain and symptoms, and then you might move on to a whole kind of program that targets everything from balance to fitness to strength in the whole program. Just a bit of support. So this comes from the Royal Australian College of General Practitioners, and they say that we should strongly recommend offering land-based exercise for all people with knee and hip osteoarthritis to improve their pain and function regardless of their age, structural disease severity, functional status, or pain levels. And that was back in 2018. And the key thing to take away here is that it's regardless, or exercises regardless of your age, your structural disease severity, your function, or your pain. So no matter how old you are, how severe your pain is, how limited your function is, there is something that you can do. And that's why it's an individualized program. We find out what you can do, and it may be something very light and very small that's potentially more than you're currently doing, that's going to add benefit, and over time that increases along as your symptoms and pain decrease, to allow you to do a lot more in your day-to-day tasks. And that's really the goal of this. There's something exciting that can come from this, which I really like. Then we touch on to the second line treatments, and again, they're not as a replacement. So ideally you're using these in adjunction. If you're just using this as your only treatment, you're probably not going to get the same benefits. If you're someone who lacks strength, no matter how many sort of extra things you do, you're still going to have that limitation. So that's where exercise comes in, as it actually achieves one potential limitation that you may have. Just touching on a bit of information, essentially it's something that we see in our day-to-day lives all the time. Panadol is something that essentially we all use, most of us use, but it is kind of a weak pain relief. So in the short term, it may be effective. Long-term results don't show much more improvement. They are generally safe, but long-term use does have the kind of effect on your liver and gastrointestinal systems and your kidneys. So if you're someone who doesn't need to be on them long-term, then it's something you may want to discuss with your GP about kind of easing off all those factors. Same with what we call non-steroidal anti-inflammatories, so your Nurofen, your Voltaren, a lot better at improving pain, but again should be done in a short dose, so not long-term. And if you're someone who does have a chronic heart disease, such as any heart disease, then they're definitely not recommended. General information, all medication do discuss with your general practitioner, and get guidance on as well, but something just to be that you're also informed, so you're not just taking this because you think it will help or it's good for you. It's being informed and making the right choice for yourself. Opioids, hopefully we're not being prescribed opioids for just osteoarthritis. As a fact that they're not very good at improving osteoarthritic pain, and they come with lots of adverse side effects. And so the Royal College of General Practitioners recommends against prescribing those or taking those. Again, just something to be mindful of. You may have heard of cortisone injections for not just osteoarthritis, but other conditions. it can be effective in the short term for about up to 6 weeks. Some people don't experience any pain or relief from them as well, so it's important to be aware of that. Interestingly, repetitive use can lead to loss of cartilage. The study comes from having 4 injections a year for 2 years, so that's quite a lot than what most people have or prescribe. But again, something to be mindful of if you are someone who has cortisone injections, and having that discussion with your GP again to make sure that you're not pushing that because of the effects that they can have. 2 other injections that are less heard of. One of them is the hyaluronic acid. Lots of clients say to me, I wish we could spray some CRC on my joint to improve it. Kind of what this is, like the basis is, it's all about replacing that joint fluid. Doesn't have the same effect as CRC does on joints, so don't try that. There's some evidence to support that it's benefit in the long term, in the short term, but with all kind of injections, there is some risk of infection. So again, being mindful of that. At this stage, evidence doesn't support with or against it. So it's a discussion that you could have if you feel the need to. The other one being platelet-rich plasma, where you take your own blood out, they process it so your platelet levels are higher, and then they put it back into that area. Sort of a newer thing, and it's starting to show some evidence to support it, but at the moment there's not enough to be considered.
Have you heard of Euflexa?
Potentially for another name, but if you could go into more detail.
That's what I was
So
good.
Euflexa.
Euflexa.
Right.
Yeah.
I haven't.
It's supposedly reasonable for knees, not so good for hips, but I've
Right.
been given it for hip. Yep.
I'll note down for myself to check into to see is it as well. And now I just want to talk about surgery, and I say it's a last resort as ideally you've had the chance to trial the first 2 lines of treatments before progressing to surgery. One surgery that you may have heard of is laparoscopic surgery. What it looks like, what it means is literally just to look inside the joint. These surgeries don't say what they're doing. Some can just be looking inside the joint to see the degree of degradation inside the joint. Others are commonly sort of joint cleanup or debridement, where they take away sort of excessive bone spurs or bone growths to make it more kind of smooth. What's interesting though is that when they compared this surgery to what I call fake surgery, where they just put someone under general anesthesia, put a hole in the knee, like a needle, take it out, general terms, the results showed no difference between the placebo, so the fake study, and the actual laparoscopy. So kind of shows that there's really no benefit to it, and at the moment it's not actually recommended, and it's not even funded by Medicare, which kind of points that it's not too effective. Say one more thing, and that was it. Then we get to joint replacement surgeries, and so they are a good choice for the right person. And they should be, ideally not provided to anyone who hasn't had the chance to try the first 2 treatments, but if you've tried those first 2 treatments and still need it, then that's a good option for you. Something like with those who've done the GLA D program and just the minimum dose, around 2/3 of those who came in expecting surgery delayed the surgery for up to 2 years. Some people come in and want surgery and no longer need it, and then some can delay it up to at least 2 years. The benefit with going through this program, or any program where you're working on your physical activity and your strength, is that you're going to improve your outcomes post-surgery, especially through rehab, because you're going to have that improved level of strength, range of motion, and also that body awareness of how to move your body and what's recommended for strength recovery. All gets placed into that kind of learning system, so when you do have the surgeon come out on the other side, you're a lot better equipped for it. So some people may come in here and think, why do this when I can just get surgery and be on my merry way? And that's fine, but I think if we can improve the whole joint first, and the surrounding muscles add stability, then post-surgery we're going to be a lot better off than if we just jump into surgery and still have those limitations that are there prior to surgery. But with the surgery, it's just important to be aware that not everyone has a great result, and we always hope so, but there are complications and costs associated with joint replacement surgery. And depending on your severity and where you're, especially for knee joint replacement, you may not get the whole joint replaced. You may only get what we call an ostomy, so it's a small wedge that gets placed that provides support to the knee rather than getting the whole joint replaced, but you'd have these discussions with your orthopedic surgeon. I just want to talk about the results that have been reported. This is from the 2021 annual report. Hopefully by the end of the program, regardless of everything, you'll improve your confidence around using those affected joints. The pain is about 27% for the hip and 33% reduced in the knee, with the improved quality of life of 22 to 33%. Taking less pain medications by nearly half, that has quite an influence on your overall health, which can be quite good. Less sick days good for you and your employer if that's a factor. And like I mentioned, it can delay or even prevent surgery, which can be a whole different life, depending on them. But at the conclusion of the GLAD, it's important to discuss what's next for you, what are your goals going forward. Have all the boxes been ticked? Are there things that you still want to work on? Is there things that you've now got some new added function that you haven't been able to do before, and some new goals that you want to set with this new function that you have? So things to reevaluate afterwards. A busy slide, but hopefully everyone can see it. This is just detailing kind of what the whole program looks like in a flow chart. So if we go to my mouse click, yep, up the top, that's where you have your initial appointment. If you're new, we haven't seen you in at least 12 months. If you're a current client, then we can skip that. But it's more so finding who you are, not just your arthritic joint, but your whole person, finding what makes you tick, why you're here for, what you want to get out of this, any other things we should be aware of, plus appropriate outcome measures, so those things we can assess the current level of function. Then you would have, I've gone too far. Then you would likely have a subsequent appointment where we can go through your individualized programs so that you're confident in what you're doing prior to starting the group classes. That's sort of in between, just before there. We also have the education session. So this is the first one on the left. And then if you were to continue, there'd be a second one where we go through more about exercise, activities, daily living, and different sort of management strategies for yourself. And then we get to the exercise component, so the second to last block. Ideally, and the results show that there's better outcomes if you do it in a group. And I imagine that's from the social element, that having that supervision and being with like-minded individuals. However, you can do it just one-on-one with your exercise physiologist, or you can also do it at home via telehealth or without supervision. But supervision does appear to show better results, so it's something to keep in mind. And then a follow-up is ideally 3 months once you start, so pretty much at the conclusion of the program. We want to reassess the initial outcome measures to see if you have progressed in your strength, your fitness, your pain symptoms, or not. And then with the GLAD program, and this is an optional choice, and I'll talk about this more in the future, but they send out a questionnaire to yourself, a survey, so you can report back 12 months post doing the GLAD, how you're feeling now, if anything improved or not.